This video is about psychiatric hospitals and community mental health centers. From the first little bit in the slide, it looks like it comes from the University of South Florida.
Welcome. If you are viewing this video on YouTube and you're not one of my students, I suppose it'd be helpful for me to give a brief introduction to who I am and what this presentation is about. This is a recorded lecture for the students in my Counseling and Community Settings class in the Rehabilitation and Mental Health Counseling program at USF. Recorded originally for the summer of 2016. The Rehabilitation and Mental Health Counseling program is kind of unique at USF because you can think of it sort of like a dual major. It's a program that is both designed for students who are interested in the specialized work of rehabilitation counseling, which is working with individuals with disabilities with the outcome of improved or enhanced independence and autonomy, primarily through work. So it's mostly vocational rehabilitation counseling, but it is also a clinical mental health counseling program. In this particular class, we're going to mostly focus in today's module on the mental health counseling component because there's an awful lot of overlap with some content in our rehabilitation counseling concepts and applications class otherwise. We're going to be primarily using information from today's lecture from a text which is Newsom and Gladding's 4th edition of Clinical Mental Health Counseling in Community Settings, but we are going to supplement it with some other resources as well. We are not going to be covering topics like private practice or employee assistance programs or insurance companies today, nor are we covering rehabilitation, or more forensic counseling. Those are going to be covered in other modules. But we're going to kind of give an overview of some of the different settings in the community that mental health counselors can work in. Now I'm going to preface this by saying that as we go through the slides here, we're going to be doing a little bit of review on some concepts that we covered in earlier classes, specifically the history of counseling and also the professional identity of counselors. This class, Counseling Community Settings, really has a pretty broad focus because we do cover the history of our profession and what is similar between counselors and other types of therapeutic professionals, and what are the differences between counselors and other types of professionals.
Honestly, this one is probably just good for me to listen to because it seems like it's an overview of a lot of things I've already learned, plus some of the other videos I've done with including the history. So, I don't know. I might learn something new. I might just, reaffirm some of the things and go over it. But either way, thanks for watching.
We also cover emerging issues in our field, licensure and certification and association. We cover advocacy. We cover disaster preparedness and response, crisis intervention. There really is a pretty wide range of subject matter that we cover in the class, but it can be thought of as a focus on the industry or the profession itself, more so than on specific clinical issues with client populations, although there's, again, a lot of overlap. So let me get to a slide here where we just give some examples from the text on some of the settings in the community that mental health counselors can work in. We have community mental health centers, of course, which are outpatient programs that provide medication, case management, and counseling to individuals. We have hospitals, such as psychiatric units in hospitals or psychiatric hospitals. Marriage and family therapy clinics. Memory disorder clinics, that is an interesting one because a lot of people may question, well, what do counselors have to do with memory disorder clinics? But there is an awful lot that counselors can do. There's a little bit of overlap between what professional counselors can do working with clients with memory disorders or with neurocognitive disorders and what, say, occupational therapists might do, for example, because we might help with some very practical strategies to help compensate for memory deficits. We also can work in sleep centers, and the reason we can do that kind of work is that CBT, or cognitive behavioral therapy, there's a lot of evidence that CBT can be very helpful for people with a number of sleep disorders. First of all, because a lot of sleep problems are secondary to mental health, other mental health disorders like depression or anxiety, and that sometimes by working with therapists and doing CBT work, clients can work on some of these underlying issues that are contributing to their sleep problems. But also because a lot of sleep problems in the United States are connected to lifestyle. They're connected to choices that we're making, habits and behaviors that we're engaging in on a daily basis, ranging from things like lack of exercise to poor sleep hygiene, to diet, and some of our tendencies to watch or read emotionally activating material or content late at night, bright artificial screens all over the place at night, all kinds of things that counselors can work with clients on when it comes to sleep problems. And the idea here is to try and get to the underlying problems underneath the sleep difficulty. So we also have substance abuse programs. There are outpatient substance abuse programs, intensive outpatient, partial hospitalization, residential. We'll be talking more about that later. Child and adolescent outpatient settings, residential programs, sexual abuse clinics, geriatric services. That's one area that we're going to see a lot of expansion in our field because the average age, as we've discussed earlier in this class, the average American is living a longer life than we used to historically. It's not that the maximum life expectancy of human beings has increased dramatically. It's that a larger percentage of the population are reaching those maximum ages that human beings are capable of living to. And so with increasingly the baby boomer generation is headed into retirement, and we're going to have a lot of elderly Americans who are going to need a lot of services, and that includes mental health treatment. And I think for the elderly, mental health has been ignored in many respects. And we have student wellness services. We're not going to spend a lot of time on things like college and school counseling today because we have other modules where we'll be covering that information in greater detail. But this is just a sampling of some of the community agencies that counselors can work in.
Hello. So out of this list that he's given for community agencies, I could see myself working in a hospital, memory disorder clinic, sleep center, substance abuse, child and adolescent, more with the adolescent side of it than child, residential treatment, substance abuse clinics, geriatric, student. Preferably though, I'd want to either do like case management stuff, which is done with community mental health clinics, which I think would be the top thing. But anyway.
Now a little note here on scope of practice. Remember that historically counselors started off at the turn of the century, in the 20th century, the early 1900s. We were primarily psychometricians. So we were actually pretty good experts in testing, whether it's IQ testing, the early IQ tests, or vocational testing like the strong interest inventory. We were primarily career and lifestyle choice counselors. So we were kind of guidance counselors at our roots, but we were also psychometricians. And our field gradually shifted until you get to the 60s. We started expanding pretty significantly into mental health. And we, by the 70s, were getting licensed as psychotherapists, basically, doing mental health counseling. So we didn't start to focus as much on pathology until the 60s and 70s in our field. We now have a very broad scope of practice. And this is an important issue because although other therapeutic professions like social work and psychologists and marriage and family therapists are resources and allies in our work with clients and in advocacy for mental health and wellness, once in a while one of these groups will try and do some kind of lobbying that could actually harm our profession as counselors. And in my opinion, you don't see counseling associations ever trying to make it so that social workers can't do something or psychologists can't do something. What we do more is we defend our scope of practice against attacks. For example, there have been some documented scenarios in some states where psychologists are lobbying to try and prevent counselors from being able to administer and interpret psychological tests. This is ironic because, again, counselors, even in the early 1900s, were primarily psychometricians, but nonetheless, there are psychologists who advocate for this, even though we get some training and testing, and even though a lot of us will continue on and get more specialized training and testing after we're done with our graduate school experience. There are still groups out there that try and lobby for us to lose ability to do certain things. Sometimes they lobby for us to not be able to diagnose mental disorders, even though that's perfectly within the scope of our practice and consistent with our training and experience. Now, I don't want to suggest here that you graduate from a counseling program and then a couple of years later maybe you become a licensed counselor and now you're an expert in everything that counselors could possibly do. That's certainly not the case. But you have the opportunity and the option of continuing with your training and experience to become a specialist in one or more areas. As a general counselor, you're kind of expected to know at least a little bit about a wide range of subject matter. But eventually you kind of start to specialize in specific areas, and in those areas you know an awful lot and you become an expert. And if you become an expert, for example, in administering and interpreting psychological tests, well, great. But there are people out there that sometimes will try to block counselors from being able to do these kinds of things. So that's sort of my professional advocacy side note here. We're going to now venture out and take a look at mental health hospitals or psychiatric hospitals. And we're going to start with the history of these institutions because this is one of the settings that are options for counselors to work in. The first psychiatric hospital was opened in 1773. So this was actually before the Declaration of Independence, which was in 1776. The Virginia colonial government opened the first state facility that was solely focused on caring for the mentally ill. It was called Virginia's Eastern State Hospital, and this sort of marked the beginning of state governments taking a central role or responsibility in providing mental health services to the citizens of those states. At the time, when we start to get into post-Constitution United States, mental health care or health care in general, if it was even under the purview of government, would have been considered under the purview of state and local governments and not under federal government. That's federalism and its separation of powers and that sort of thing. We get into the 1800s. New York and Connecticut opened state psychiatric hospitals in the early 1800s. But really still in the 1800s, especially the early 1800s, many people with mental illness would just end up in jails or prisons or poorhouses. And some people would say that we've unintentionally come full circle to that point today, but we'll get to that later. Moving into the mid to late 1800s, we have a key historical figure, Dorothy Dix. Dorothy Dix was a nurse, and she was also an advocate for more humane treatment of people with mental illness. And Dorothy Dix had a lot to overcome because in this time, in the mid to late 1800s, many people would just simply not accept women as having a substantial role in healthcare in the United States. So, for example, Dorothy Dix was I think the actual position was superintendent of Army nurses during the Civil War. And there reportedly were surgeons who refused to work with her because they thought it was inappropriate for a woman to be in such a position. So she had an awful lot to overcome in that sense. It was very difficult for women to really become a medical professional at that point in our history, unfortunately. But at this time, we still use a primarily moral model when we focused on mental illness. We still often regarded mental illness or behavioral problems as being simply a matter of poor choices or immoral reasoning, and so we thought that if we would just sort of lecture and educate people, we could kind of guilt them into changing their ways. And that was a prevailing notion during this time period. We really weren't oftentimes conceptualizing mental illness as illness. We weren't thinking from a medical model as much as we are today. By 1870, there were 42 state psychiatric hospitals with 14,605 residents. So this really caught on. Now, you may remember from our overview of the history of professional counseling that there's a reason that in the mid to late 1800s, we started to see an expansion in mental health care, and we started to see state governments taking on a significant role in this area. And that's because this was the era of the Industrial Revolution, a period of time when we would have one technological innovation after another, creating a domino effect of incredible discoveries, ingenuity, a lot of invention. And with this new technology, we began to shift more away from an agrarian rural society towards an industrial society that could mass manufacture, and we increasingly were becoming specialists. We all do one specialized activity vocationally that contributes to a much bigger picture. And with the Industrial Revolution, many benefits came. Poverty increased and has continued to increase in industrialized nations since the beginning of the Industrial Revolution. Food became much more readily available, as well as other goods and supplies, and clothing and so forth. And new technologies led to advancements in healthcare, so that over time, human life expectancy in industrialized nations would increase substantially. So there were many benefits of the Industrial Revolution. But it came with a cost as well, because we would have people moving from rural areas into these highly concentrated, dense populations in urban centers. Well, what comes along with this? I mean, prior to the Industrial Revolution, in these more rural areas and small towns, people kind of know each other. They know each other's needs. They know who has legitimate needs and who's sort of scamming the system. They have methods put in or processes put in place to handle unique needs. People with mental illness would primarily be helped by their family members because they live in the same communities that maybe many generations of their family have come from in some cases. And they usually have an intact support system from a young age prior to the Industrial Revolution. And then the community sometimes would pick up, and neighbors would pick up to chip in a little bit when a family was going through a particularly hard time. These were common practices in these communities. But people move away from these communities with the Industrial Revolution and into highly concentrated urban areas. Sometimes they might be, say, a younger person in a family moves to the big city and starts working there. But let's say that they have genetic predispositions for schizophrenia or bipolar disorder, and they start to experience their first substantial psychotic symptoms in their young adulthood while they're in one of these urban centers. And eventually they become delusional and they're hallucinating or something along those lines, or they're in a manic episode. No one really knows who are these people and where they came from and what their real needs are. And so the question is, who's responsible for caring for them so that they don't interrupt society? They don't create a problem for other people that are living side by side with them or interacting with them in these urban centers. And the government was turned to for a lot of that responsibility. And so we begin to see during the Industrial Revolution an increased role of government and mental health care. Not that the care was necessarily high quality care compared to today's standards, but we were beginning that care during the Industrial Revolution. We're going to skip that slide and the link for it, and we're going to go into the 1940s here. In the 40s, we get into World War II. Now remember from the history of professional counseling that every time something disastrous happens nationally or globally, there seems to be it seems to trigger a bit of growth in the industry of professional counseling. In the 40s, 1.75 million men were ejected from military service because of mental or emotional issues. And this raised awareness for mental illness, because this is a time where we really needed people for the military. In 1948, we have the publication of The Shame of the States and many other writings that would raise awareness of problems in the state hospitals. Another book a lot of people are familiar with is A Mind That Found Itself by Clifford Beers. Moving into the 50s, We have the 1954 National Mental Health Act authorizing the National Institute of Mental Health to provide leadership and research and improve provision of services to people with mental illnesses. NIMH was under the National Institutes of Health, which is now under the U.S. Department of Health and Human Services. So it kind of is a big deal when it really helps to create recognition for a particular form of medical specialty, in this case mental health, when the government begins to recognize it and creates a branch, a research institute dedicated to that area of specialization. Moving into the 70s, remember from our previous lecture on the history of counseling that in the 50s and 60s we had the tremendous expansion and success with the civil rights movement. The civil rights movement has always existed in the United States for as long as there's been a United States, but we really got some momentum going in the 50s and 60s for many reasons, and one of those reasons I brought up previously was the availability of television sets in American households so that people could watch as people were brutalized simply because of maybe the color of their skin. And this would activate mirror neurons within people and increase empathy and activate that natural human instinct for justice or protection for quite a large subset of the population. And this kind of helped, among many other variables that came together in the 50s and 60s, to trigger some improvements in the efficacy of the civil rights movement. But in the 70s, that civil rights movement that dealt with race and gender or sex began to really expand to mental illness. So we had a series of Supreme Court cases that were based on the reasoning or rationale of previous cases that dealt with racial equality that made it hard to continue some of the inhumane practices that we had for people with mental illness, where we were actually really infringing on the rights of people with mental illness. So there are some videos that we could watch at this point. I am going to show two videos during this broadcast. The first one, I'm not going to show you the link that says Inside the Closed World of State Mental Hospitals. It's an interesting lecture there that deals with, from an architectural standpoint, what seemed to be the intention of a lot of the early psychiatric hospitals in the U.S. But instead I'm going to show you two video segments. The first one is Early Treatment of Mental Disorders. This is a graphic video in the sense that you will see a few things, just a little bit of, there's some brief nudity. You're going to see some insulin-induced shock treatments that may be a little uncomfortable to watch, but you also see briefly a little bit of footage of a lobotomy. So I just want to give you that warning for people who are a little bit squirmish here. But I think it's important for us to be exposed to the historic context here. So I'm going to show the video now, and then we'll do a little brief discussion afterwards. Here we go.
During the first half of this century, mental hospitals tried to use medical treatments for people with severe mental disorders. However, the medical procedures used were crude, largely ineffective, and often unintentionally cruel. Some of the leading approaches are shown in this segment. A popular technique was hydrotherapy, in which patients were sprayed by water in order to stimulate them. The wet pack consisted of packing, that is, wrapping patients in wet sheets. This next procedure, the continuous bath, was kept at 98 degrees Fahrenheit. Its aim was to sedate patients. Hot boxes and lamps were used in order to help relax patients. A predecessor to electroconvulsive therapy was insulin therapy, although this approach was more dangerous and less effective than ECT has since become. Insulin therapy was developed by Viennese physician Manfred Sackel. It was used primarily on patients with schizophrenia. The idea was to give patients insulin, which would make their blood sugar drop. The patient would then slip into a coma, and most importantly, would experience a convulsive reaction. One form of reaction brought about by insulin therapy was called wet shock because it included profuse sweating and drooling, as seen here. Another reaction brought on by insulin therapy was so-called dry shock, involving a full brain seizure. Glucose, given by nasal tube or by injection, was needed to bring patients out of their insulin-induced coma. Metrosol therapy, an intravenous injection of metrosol on patients, again primarily with schizophrenia, was another form of convulsive therapy that was used prior to ECT or electroconvulsive therapy. It was developed by Hungarian physician Vanislav Meduna, and the intravenous injection of metrosol typically produced grand mal type seizure. Finally, one of the most notorious of all early procedures was the lobotomy, a brain operation in which a surgeon would cut the connections between the cortex of the brain's frontal lobes and the lower centers of the brain.
Okay, so that is a look at some of the kind of crude, at least from today's standards, treatments were available in some of these psychiatric hospitals, and say around the 50s and 60s and that kind of era. Now, a few comments about this. Normally when I show this in class, I ask for students to talk about their responses as they watch these videos, and they have a lot of very unpleasant reactions as they watch this footage. They think, oh my gosh, this looks mean, it looks cruel, it looks abusive, this is horrible, it's horrific. And they're usually very critical of what they see in these videos, and that makes a lot of sense. I mean, frontal lobotomies, for example, I mean, that is such a hugely invasive and unethical kind of a practice. But when we look at some of these treatments, I mean, a lobotomy was not a very common treatment in the sense that the majority of patients wouldn't be given frontal lobotomies. It was kind of a last-ditch effort sort of a strategy, and a lot of times in more forensic scenarios. But things like the insulin-induced seizures, there actually was evidence that this could be helpful for psychotic disorders like schizophrenia, or for the more manic presentations of bipolar disorder. There was evidence it was helpful, and in fact, it's sort of a precursor to today's electroconvulsive therapy, which is a very empirically supported and relatively safe, even in comparison to antidepressant medications, a safe and ethical treatment to use. It doesn't look pleasant. The concept doesn't sound pleasant. I've had a few clients who have participated in ECT, and they all liked it. They thought it was very helpful. They had good results from it. And I hear that consistently from people, but these were precursors, crude, sort of antiquated, outdated versions of what we have available today. And what we have today was built on the foundation of what they were doing back then. And this was also an era where we didn't have the antipsychotic medications that could help people to stabilize on an outpatient basis. We were just getting those medications during this period of time. And so they were kind of, I think, doing the best that they could with what they had available to some extent. Certainly, there were a lot of abuses within these psychiatric institutions and a lot of examples of inhumane treatment. But I think there was also a lot of quote-unquote good treatment when we consider it in context of what kind of technology and information we had available at the time. And I think that's something important to pay attention to when we critically look back at this history. These are the foundations that built us to where we are today, and we still have a lot of room to grow going forward into the future. Now, a second video that I'll show you is, I think about, I want to say maybe 15 or 20 minutes long. It is an old video from the 50s. I think it was produced by the Oklahoma State University for their state psychiatric hospital. It looks like the kind of video that they maybe would have once shown in a movie theater before showing a main presentation during that.
So I didn't feel like actually going to the website to find that video, or to YouTube. I might type it in YouTube and do a different video with that in it, but this video is already long enough with what he's saying. So anyway, back to what he was saying.
So this kind of gives you a little bit of a flavor. Of course, that second video that we watched, some people watch that and say, well, this is clearly propaganda, and certainly it was created by the government with a particular goal in mind of supporting or promoting the psychiatric hospital in the state of Oklahoma. Some of the things that they did, when I asked students who watched the full video, what did they see that they do think could be therapeutic for patients, and what did they see that they don't think would be so therapeutic? And usually it's things like the insulin therapy that's not therapeutic, or giving the patients cigarettes, for example, to smoke with the doctors and things like that. But the social aspect, the encouraging social interaction, dances and hobbies and vocational part, and being able to talk to people who are supportive and listening, those aspects are usually more the aspects that people find to be therapeutic when they look at these old ways of treating people. So we've come a long way, but what you'll see today is not a whole lot of long-term psychiatric hospitalization. That's pretty rare anymore. Now what you're mostly going to see is short-term stabilization in psychiatric hospitals today. We're talking about maybe 3 days of hospitalization to maybe a couple weeks. Very short durations where they pretty much release people as soon as they're no longer an imminent threat to themselves or others. They may still be in a really rough spot and really be struggling, but they'll still discharge them if they're no longer an imminent threat. So usually when delusions and hallucinations are cleared up, for example, or the person's no longer manic, in the case of bipolar disorder, people will tend to get discharged even though their needs are still really strong. So that's a criticism of the current psychiatric hospital setup. So if you were a counselor working in a psychiatric hospital in the present, unless it's a state hospital where we are doing more long-term hospitalization, you're going to be doing not a whole lot of counseling. It's very short-term work, crisis and stabilization oriented. That's probably the reality in a psychiatric hospital today. But then we got to deinstitutionalization in the 60s. We talked, when we went over the history of counseling, about some of the variables that came into play that helped us to deinstitutionalize at a more rapid rate from the 60s to the present. And those variables include the manufacturing of antipsychotic medications by private pharmaceutical companies. And these medications made it possible for people to start stabilizing on an outpatient basis and still, with the right kinds of support services, be able to function. A second variable that we talked about was the impact of the civil rights movement, and particularly in the 70s, when those landmark cases from the civil rights movement created a precedence for us to begin to also reform how we treated the rights of people with chronic and persistent or severe mental illness. But there are some other variables that came into play as well. One was a bipartisan push to deinstitutionalization, because on one hand, deinstitutionalization allows people to be able to stabilize in a community, be more integrated, have more self-sufficiency, independence, and autonomy, and live higher quality lives. And on the other hand, it's fiscally responsible because it costs a lot less money to stabilize people on an outpatient basis than it does to hospitalize them. So when we got the Community Mental Health Centers Act of 1963, this created some funding for community mental health centers to try and stabilize people on an outpatient basis, and in some cases work with people who are transitioning out of the psychiatric hospitals. And over the years, that funding shifted from federal funding to more state and local funding. Today, what you will see in a lot of community mental health centers, frankly speaking, is that they have a tendency to work with lower income individuals with mental illness. People who maybe have Medicaid or Medicare as their primary funding sources. And that's how a lot of the federal funding comes into play. A lot of it comes through Medicaid and Medicare, because so many of the clients in community mental health centers have government-funded health care. Medicaid's unique because although it's funded by federal, state, and local funds, it's run by the state, and so Medicaid policies and rules may vary from state to state, and they are focused on low-income individuals and families. Quick mention about SAMHSA, the Substance Abuse and Mental Health Services Administration. This is a division of the U.S. Department of Health and Human Services, or DHHS. It is a federal agency that's charged with improving the prevention and care of substance abuse and mental health disorders. So a lot of research comes from SAMHSA, as well as treatment protocols and best practice guidelines and so forth. And a lot of their materials are available for free through their clearinghouse, where they will actually even ship you, in some cases, mass quantities of materials at no cost to you, including free shipping and handling. So some of the guiding principles of these community mental health centers will focus for the next few slides on community mental health centers. The first principle is that services should be accessible and culturally sensitive to those who seek treatment. Makes sense. We want people to be able to access care, and we want to be able to respect or be sensitive to some of their cultural norms as well. And these CMHCs should be accountable to the community because they are primarily publicly funded. And that community includes people who are at risk and underserved. The services shouldn't just be medication maintenance, for example. They should be comprehensive, flexible, and coordinated. People should have comprehensive treatment plans, meaning that they get a wide range of services depending on their needs. Not just medication, but maybe also they need therapy. Maybe they need group therapy or peer support or recovery groups. Maybe they need vocational services. Maybe they need to be connected to primary care treatment because of co-occurring medical disorders that aren't mental disorders. And we should ensure continuity of care as people transition from one level of care to another. Healthcare needs are holistic. We look at the entire person and not just one aspect of their functioning. You may notice a lot of these guiding principles are very consistent with the guiding principles of the profession of counseling itself. Prevention and early intervention are the most essential services provided, and treatment providers should use a multidisciplinary team approach to their care. Now, although these are guiding principles for community mental health centers, unfortunately, and I hate to sound pessimistic, but in my experience and in the experience of other people that I've spoken to, including many of our students who work in these settings, unfortunately, a lot of these principles aren't necessarily embodied in practice. For example, there are community mental health centers here locally where people can get in to get their medication, but it might take a couple months before they're able to be seen by somebody, or a few months. They may be on a waiting list. And once they do get it and start getting their medication, let's say that they need therapy or counseling also, they might have a waiting list to get a counselor. When they do get a counselor, they tend to only get 30-minute sessions instead of 60-minute sessions, and these sessions may be 2 or 4 weeks apart, so they can't get the more intensive or more frequent counseling or psychotherapy that they need. And sometimes referral and case management to vocational resources and other resources that the person may need to help stabilize is lacking. Transportation is often an issue too. And many community health centers do the best that they can to try and cover some of these unique needs, but they often have very limited resources, and that makes it very challenging for them to accomplish their mission under these guiding principles. So they really do have a unique challenge of trying to do the best that they can to address a wide range of needs for a very challenging population with very limited resources. And so when I say that a lot of times the care is lacking in terms of these guiding principles, it's not a direct criticism of the community mental health centers themselves, but also a direct criticism of the resources they have available to them to do their job. Now, according to the text, these are services frequently offered by community mental health centers: outpatient counseling services, day programs including partial hospitalization and IOPs or intensive outpatient programs, emergency services and crisis intervention, substance abuse services, case management and outreach, education and consultation, residential programs, and inpatient services. The problem with this list is that, at least here locally, and we have an area that has rich human services or community resources compared to many other areas because we are a metropolitan area here in the Tampa Bay area of Florida. But even the community mental health centers here rarely have all of these services and often have few of them. So let me give you a couple examples. I mentioned in some local community mental health centers, yeah, they might be able to get counseling, but there might be a waiting list. They might be short sessions with relatively new and inexperienced counselors, and they may also be spread too far apart. Monthly check-ins is what a lot of times these counseling services start to look like. It's not like that in every community mental health center, but in many of them it's like that. Many CMHCs do not offer PHP or IOP levels of care. Certainly the ones here locally, most of them do not in the Tampa Bay area, but there are a couple who do. Emergency services and crisis intervention, some of the local CMHCs provide that service, some do not. Substance abuse services, none of the CMHCs locally are licensed substance abuse treatment programs licensed under Florida DCF here. But some of them say, well, we have programs that are designed for people who have some substance abuse needs, and we can provide some support work there, but we certainly can't treat the more severe substance-related issues. They need to go to a specialized agency for substance abuse care in that case. So it's pretty limited what CMHCs do when it comes to substance abuse treatment. Most of them don't do urinalysis drug testing, for example. Most of them don't have CDIOP, which is chemical dependency intensive outpatient. They may have like a group for people in recovery that meets once a week. They have counselors who maybe try to do some relapse prevention work along with their mental health care, but they're pretty limited in what they can do. Most of them don't offer detox services and things like that. In my experience, they do a little bit better with case management and outreach services locally. I don't know about education consultation. I don't know if I see a whole lot of that. None of them seem to have residential programs, but some of them do have inpatient services for acute hospitalization needs Most do not. Most say, you have to come to us after the client has gone through hospitalization in one of the local hospitals. So this is a nice list here, but I'd be hard pressed to find a CMHC that offers all of these services. Now we're going to go down a little tangent here for a moment and talk about different levels of care for mental health and substance abuse in the community. We're going to take a look at this through the lens or the filter of the ASAM treatment criteria, or the ASAM levels of care. Now, first of all, what's ASAM? It's the American Society of Addiction Medicine. This is predominantly a group more catering towards physicians or medical doctors, but they do actually have memberships available for other allied health professionals, and they actually create their criteria with many different stakeholders at the table, many community groups, medical groups, counseling groups, NADAC, the Association for Addiction Professionals, which is a common association for substance abuse counselors to join, would be an example of one of those stakeholders who are part of these developing and modifying these criteria as time goes on. Currently, the ASAM criteria really are kind of the gold standard model for levels of substance abuse care in the United States, and they've expanded to focus also on levels of mental health care. The most recent addition for their criteria is the third edition, which was released in October 2013, so it's now been out for, I guess, going on 3 years here, but not quite, about 2.5 years at this point. So I like the ASAM model because, first of all, it is holistic. And a little bit more about the history here. In the 80s, there were different groups that were trying to create criteria that could be used to more objectively assess a client's needs and then match the client to the appropriate level of care based on those needs. The demand for this came in part because of managed care. Increasingly, Americans were relying on insurance to fund mental health care. And insurance wants to make sure that when it's spending money, that it's being spent because it has to be spent or needs to be spent, that it's considered medically necessary. Well, how do you know if something's medically necessary? Is it just because a clinician says it is? Or does the clinician need to provide some more objective information that's a little bit more universally recognized and accepted to justify that level of care? Now, some people would argue managed care went too far, and in many cases, managed care denies appropriate levels of treatment to clients who really need that service because they're being stingy with their funds. I kind of take a slightly different approach. I kind of see it as a necessary evil. It makes sense to me that insurance companies, to be responsible and to stay in business, would require some kind of evidence that a level of care is needed, because frankly, when you go back to the 60s and 70s, for example, a lot of counselors would just say, oh, this person's got substance-related issues, then they need to go to rehab. But a lot of clients don't need to go to rehab. And these models focus on the least intensive or least restrictive level of care that's medically necessary. Why would you send a client who has mild substance abuse and would respond well to outpatient treatment to a residential program and disrupt their lives for 30 plus days, and with all the implications and consequences that come along with that, along with the funding, the funds that are being spent on it that could be spent more efficiently when they may not need that kind of level of care. And yet a lot of counselors would just default to rehab if you have substance-related problems. And there's not a lot of logic to that. So I am a fan of some more objective process, and I think ASAM does a pretty good job of being holistic and relatively objective and providing a rationale that anybody, whether they're a medical professional or a third-party payer, can sort of understand and respect in some way. So I think that the rise of managed care brought some benefits and drawbacks, but one benefit is that we don't just willy-nilly get to tell people what level of care they must go to because we say it, but that we have a rationale, that we're using appropriate assessment to really look at, on a case-by-case basis, the individual's unique needs. Now, the ASAM criteria sometimes clash with third-party payers too. I'll give you some examples of that as we go through here, but most third-party payers like the ASAM criteria because they want a more objective process for making these determinations. So it starts with a multidimensional assessment. And in the ASAM model, there are 6 different dimensions that we use to assess an individual to find out what their treatment needs are. Dimension 1 is acute intoxication and or withdrawal potential. And by the way, the ASAM criteria has been around since 1991, when a lot of these different groups that were creating these different protocols sort of merged and began to operate under a more universally accepted paradigm. But dimension 1 is acute intoxication or withdrawal potential. So let's say an individual comes to you, you're doing an assessment, and their speech is slurred, and they drink a lot, plus on top of that they're being prescribed a whole bunch of Xanax or some other kind of benzodiazepine like clonazepam or something along those lines. And given the amount that they're drinking and the frequency, they're drinking on a daily basis, and there's evidence that if they were to cut back or stop, that they would experience withdrawal symptoms. And then you keep in mind that alcohol and benzodiazepines are 2 classes of substances for which withdrawal can be deadly. You don't want to send this person necessarily to an outpatient program expecting them to withdraw from these substances. You would really be jeopardizing the client's safety, and that would really be malpractice from my perspective. You would need to start off with a safe, medically supervised withdrawal, and that may involve them going to an inpatient detox unit for several days, or maybe even a week or 2, to be medically supervised and to be tapered down from the alcohol and benzodiazepines so that they don't suffer some tremendous medical emergency during their withdrawal process. So dimension 1 is obviously very important to assess. Dimension 2 comprises biomedical conditions and complications. So here we look at, outside of the realm of mental health, what are the other health needs of this individual? What is their health status? If you have a client who needs residential treatment, for example, when you look at these other dimensions, but they're also an insulin-dependent diabetic, you're going to need to know that you're going to have to match them to a residential program that can give them access to their insulin and has appropriate medical personnel on staff who can supervise that ongoing therapy. Or what if somebody were on dialysis because of kidney failure? So you have to make sure that people are in programs that can accommodate, work with, and appropriately treat these co-occurring biomedical conditions. Dimension number 3 is emotional, behavioral, or cognitive conditions and complications. So here we're looking at the outside of the realm of substance abuse, what are the co-occurring mental health needs of this individual? If this is an individual with schizophrenia, for example, then we need to make sure if they're going to go to some kind of substance abuse program, that program is a co-occurring disorder dual enhanced program, meaning that the staff there can co-treat the mental health disorders alongside the substance abuse disorders. That there will be a psychiatrist, somebody who can also make sure that the medication maintenance continues for the schizophrenia. There are substance abuse programs that simply cannot, are not set up to do very well with addressing these co-occurring mental health needs. Now what if they had a neurocognitive disorder? What if they had dementia? Well, how well is a client with dementia going to do with group therapy? And so matching the client to the right program is going to involve getting a sense of neurocognitive disorders and other mental health disorders that could be coming along for the ride, along with the substance-related problems. Dimension 4 looks at the individual's readiness to change. Here it's helpful to consider Prochaska, Norcross, and DiClemente's stages of change model. That's the model that goes from pre-contemplation, which is problem, what problem? There's no problem, denial basically, to contemplation, okay, maybe there's a problem to work on here, I'll consider it. And then from contemplation to preparation, okay, there definitely is something for me to work on here. I want to work on it, I'm committing to it, but I'm getting my ducks in a row. I'm figuring out how I'm going to go about this and setting the stage for that change. And then we get into action stage where people are actively making those changes, and it's uncomfortable. It's veering from normalcy for them. They're still adjusting to it. They're not adjusted yet to those changes. And then we get to maintenance, where somebody has successfully made these behavioral changes for a substantial period of time, and it's now the new normal, and they're relatively well adjusted. They need to focus on relapse prevention while also simultaneously enjoying the benefits of their recovery. Well, what if somebody in dimension 4 is denying that there even is a problem? Well, if you have leverage, as in they're legally mandated to go to whatever kind of treatment that your clinical assessment reveals that they need, you may not have to worry a tremendous amount about this, but the program you send them to would have to know that they need to use strategies and techniques that will meet this client where they're at. Because if they're in pre-contemplation stage, they're experiencing a great deal of denial. They're not going to respond well to, most of them anyway, to a strongly authoritative confrontational approach. They will probably need some motivational interviewing and some person-centered or Rogerian therapy approaches. And they're probably going to need, maybe some of them will benefit well from some group experiences where they can sit and listen to peers talk about some of their experiences and see if they relate or not. They might need some psychoeducation on what is addiction, what does it look like? What are signs that somebody could have a problem with a substance? They're going to need a different treatment approach than somebody who's accepted the need for change and is working hard on it already. Now, let's say that you determine that somebody needs residential treatment, but they're not ready to go. They will not go and you have no leverage. Well, the ASAM model does allow for you to say that although I think this person needs a higher level of care, because of their low readiness for change, I'm going to start them in an outpatient with some motivational interviewing to help them to resolve the ambivalence that's getting in the way of their need for, accepting the need for residential treatment. Then we have dimension 5, which is relapse, continued use, or continued problem potential. Here, we look at the individual's unique relationship with relapse or continued use or problems. So we look for evidence that this person's in a situation where if we treat them on an outpatient basis, they're likely to be relapsing in the near future. For example, do they have a lot of access to substances, which also connects to dimension 6 to some degree? Are they living in an environment where they have a lot of dealers or suppliers for their substances, where they have a lot of peers, family members, or friends who abuse substances? Have they been relapsing frequently even when they're motivated to change? Have they tried outpatient and they're unable to avoid relapse on an outpatient basis repeatedly? Those are all things that can be used to justify a higher level of care. Now, ASAM does caution, you don't need to take, let's say that you do an assessment and you decide residential is warranted. You don't need to experiment and put them in outpatient first, let them fail at that so you can justify residential. No, you go straight to residential. That's the medically responsible thing to do. But in some cases, they've already been doing outpatient treatment and you can use that to justify the need for residential if they're unsuccessful. Dimension 6 looks at what's their support system like and where are they living. So in their home environment, for example, is there another alcoholic living at home with a strong supply of alcohol available? Do they have friends who do not use and are supportive of their change? Do they have family members who are supportive? And there are a lot of people who simply don't have a sober support system. Heavy substance abusers have a tendency to cut off relationships with non-substance users and build them with other substance abusers. And so a lot of times this is a problem. And a person may need residential to get out of their community with their high relapse potential and into an environment where they can start to develop some sober supports. A lot of the residential programs, for example, or IOPs or PHPs, require clients to attend off-site substance abuse and recovery support groups where they can start building a support system, maybe get a sponsor if they're using a 12-step approach. So until we're able to help them develop appropriate supports, they may need something more than standard outpatient care, something a little bit more intensive. So these are the 6 dimensions, and counselors assess for these 6 areas, and they have a sense of what are this person's needs. And they use that needs assessment to determine the appropriate level of care. And you kind of see on this, this continuum here what these levels of care are, ranging from 0, which is the person really doesn't need care, to 0.5 early intervention, which is, okay, there are signs, some risk factors here, but we don't think they have a substance use disorder. We need to intervene to prevent them from developing one. To standard outpatient, which is your more mild substance-related problems in most cases, or it can be a step-down level of care for people who have more severe problems but have already successfully completed a higher level of care. And then we get to IOP, intensive outpatient, and PHP, up through to our residential programs. We're going to go into a little bit more detail. Again, I mentioned a 0.5 early intervention. This is for individuals who are at risk, but there's not yet a diagnosis. Examples might be employee assistance programs for early intervention and prevention, some motivational interviewing, because maybe there is a lot of defensiveness or denial, and we're not sure if they're really being accurate in their self-report. Maybe they do have a substance-related problem. Maybe they're ambivalent about it, and maybe we can clear that up. Educational classes for DUI offenders who don't necessarily have a diagnosis, or we haven't done a clinical evaluation yet, so we don't know if they have a diagnosis. These would all be examples of early intervention. Outpatient care. In outpatient, we have reason to, we either have made a diagnosis of an addictive disorder, or it seems more likely than not, and we're unable to get access to full information to really make this determination. Outpatient standard or level 1 outpatient can also be used for a client who needs a higher level of care, but there's a lot of denial, they're resistant to participating, and so they won't do it unless there's leverage. And you might park somebody in level 1 outpatient, provide motivational interviewing to help them accept the need for change. You may even try solution-focused brief therapy in level 1, because let's say you have a client who says, look, yeah, I have a problem with drinking, but I don't agree with you that I'm an alcoholic, and you might not necessarily use those labels, but conceptually the client may be saying, I don't agree with you that I'm an alcoholic. I don't think I need to stop drinking altogether. I don't think I need rehab. I don't think I need detox. I don't think I need AA or NA or Celebrate Recovery or Life Ring or whatever the case may be. I think I just need to cut back a little bit, and I'm confident that I can do that and that these problems will go away. Well, you may decide, if you don't have leverage, to provide the outpatient treatment. Do some motivational interviewing, give them a chance to try their plan out, use some solution-focused brief therapy, try to develop a responsible drinking plan with them. Now, if there's evidence that they could have withdrawal that could be serious or threatening, then you may require that they have to have a physician be involved who's providing some medical supervision as they taper down on their alcohol consumption gradually. But you may work with them and see if their plan can work or not. But if their plan repeatedly fails, then you may use that to help them to clear up the ambivalence to accept the higher level of care need. Now we move on to intensive outpatient, which is IOP. IOP is 9 to 19 hours of programming per week. Here in Florida, we tend to see that IOP is roughly, let me think here for a moment, 9 hours a week. They tend to go with that minimum. Usually it's like 3 days a week, 3 hours of group, maybe tack on an individual session or two, and maybe some support groups in the community on top of that are peer-run support groups. The client, again, has a diagnosis. We're getting into more moderate presentations to severe presentations with IOP. Partial hospitalization, also known as day treatment, is a minimum of 20 hours a week. And you can think of this level of care as being, look, they're just shy of needing residential or inpatient care at this point. And IOP and standard outpatient won't be sufficient for this person. And then we start to move into all different levels of residential programs. I won't go into great detail about these different levels of residential programs, but they're the levels 3 and level 4 programs. We also have levels of care that can sort of supplement the primary level of care, like opioid treatment services. Here we start to look at things like Suboxone maintenance or methadone maintenance. And we have different forms of detox, different levels of detox treatment as well. Okay, so why I showed you all that stuff was to get you familiar with the fact that there are different levels of care, different programs you can work in. Standard outpatient, intensive outpatient, partial hospitalization or day treatment, residential, and inpatient treatment and detox units. These are all settings that a substance abuse counselor works in. But there are also settings that, for most of them, that mental health counselors can work in too. For example, in mental health, you have standard outpatient, you have intensive outpatient, you have partial hospitalization, and you have inpatient and residential treatments as well. So, so the model that sort of works well for both. Now, there is another video that I'd like you to watch. I'm not going to show it right now during this recorded presentation, but it's called You Can't Not Do That. Now, you will find it, if you're one of my students, you're going to find it in Canvas, and it's going to be under the module for community agencies, medical settings, and other specialized clinical settings. You'll see it right here, You Can't Not Do That. I would like you at this point to sort of pause this YouTube video and open up that video. Now, if you're not one of my students, just go into YouTube and Google, or Google, You Can't Not Do That. And maybe add Community Mental Health Center as your keywords. This is a video that includes interviews of some of the founding figures in the Community Mental Health Centers movement. And in these interviews, they talk about some of the unique challenges that they've had to go through in community mental health centers and how they sort of dealt with some of those unique challenges and difficulties. And I want you to watch that 40-minute video so you have a realistic picture of what some of those challenges will be if you choose to work in this setting. It can be a very rewarding setting because you're working with people who really need help and helping people to stabilize on an outpatient basis so they don't need a higher level of care. But community mental health centers can also be very challenging to work in. Some of the common concerns that people have are they feel overworked and underpaid. They don't have as much time as they like, lots of documentation and paperwork, but you're going to see some of those concerns in almost any setting that you would work in the community. But you get a very rich experience, a lot of good clinical experience, and I think, even if you decide that it's not the right fit for you and you move on to another location, I think it could be extremely important and critical for your professional development. Let's say you want to go to private practice, for example. Almost every private practitioner has spent years working in community settings before they go into private practice because they get the skills and the experience to give them the confidence that they need to do well in private practice. So I wouldn't trade my community agency experience for anything, even though today I'm a private practitioner and prefer that environment. So go ahead, pause this video, watch that video, and then come back to this video and we'll do just a very brief discussion of a few points. But when you watch it, there are 3 questions I'd like you to be asking yourself as you watch the video. The first one, what were the unique challenges faced by the speakers, the people who were interviewed? What did they talk about as being the challenges as they developed these community mental health centers? Question number 2, what strategies did they use to compensate for those unique challenges? How did they address these challenges? How did they adapt and modify their approach to deal with these challenges? And the third question is, why do they even do this kind of work? What attracts them to this setting? Why are community mental health centers so important to them? Why are they willing to embark on such a challenging experience? Pause, watch the video, come back, and we'll discuss briefly. Okay, so hopefully you have already watched the video You Can't Not Do That. And if I were doing a live class, then I would be asking you to answer these 3 questions. But just a few of my thoughts about some of the things that I watched in this video. One of the big unique challenges that people talked about were the changes in budgets. And especially when there are times of economic recession, and because community health centers do rely partially on local government and state funding, and not just federal funding, when you talk about local and state government, anytime there's a deficit in taxes, or anytime there's an economic recession, there are going to be deficits in taxes. We're going to be collecting fewer taxes because people are earning less money. When there are taxes reducing, then there are going to be budget cuts because state and local governments have to pass balanced budgets. They can't spend money they don't have, unlike the federal government, which actually has some unique strategies they use to spend money that they don't have. So these local governments, if they have to cut something, human services are going to be one of the first things that they'll cut, including community mental health. Now you might say, what could be more vital than community mental health? But sometimes it's we cut human services, or we cut having roads maintained for people to drive to work, or we cut medical emergency services, we cut firefighters or police officers, or we cut public education. And so it is very difficult sometimes to manage these competing priorities with local and state government. But you can almost bank on it. Human services are going to be one of the first areas to be cut when budgets need to be cut. So the early founders of community health centers and throughout the years have had to deal with this. And one of the strategies that they used to deal with it is they started employing business people. They started bringing in consultants or staff members who had more of an entrepreneurial background, or at least a not-for-profit funding background. So they started learning how to write grants and get other kinds of government funding. They started learning how to do fundraising and charitable events to help bring in some additional forms of funding. They learned how to spend their money more efficiently, and they learned how to try to develop multiple streams of income so that they could be a little bit more recession resistant when there's a lack of funding. But they all got into this line of work because they really saw the need. They wanted to help, and they knew that it's not enough just to provide medical care to people. They need comprehensive wraparound services that deal with the whole person. And they know that without community mental health centers, we'd be stuck with the same problem that we had with institutionalization. Either we need psychiatric hospitals, which actually cost more money and deprive people of some of their freedoms and liberties and are more restrictive levels of care that some people need, or we're going to have a whole lot of homeless people and a whole lot of jails full of people who just needed some medical stabilization. And yeah, they may have committed a crime when they were hallucinating, but what if they had the appropriate outpatient treatment and they weren't hallucinating or they weren't delusional? Would they have committed that crime or not? So a big part of public safety and a big part of helping people is to have community mental health centers available. Now, a lot of people argue when we deinstitutionalized, we didn't have the appropriate support set up in the CMHCs yet. And so a lot of people, you know, if they can't get to the CMHC because they don't have transportation, or they don't have a job, they're going to end up on the streets homeless or in jails again because they might be committing crimes out of desperation. But also, you can't force people to take their medication on an outpatient basis. People still choose whether they show up to get the meds, they choose whether to take the meds consistently or not, and when they choose not to, they destabilize. So it's not like community mental health centers are a solution, but they're part of a comprehensive solution, and they, at the very least, are an example of risk reduction. So hopefully you got some of that from the video that you watched. You probably got a lot of other things from it. But since it's not a live conversation, we really can't go into it much. So my hope is that what you've gotten from this module and from this lecture is a brief understanding of what are some of the different community settings that I can work in as a counselor, what are some of the different levels of care I can work in, what's the significance of the community mental health centers, what's the history of the psychiatric hospitals, where we're coming from and the problems that we sought to remedy through the community mental health centers, how we were able to get the community mental health centers when we got them, and what might be some of the unique challenges and difficulties to deal with working for community mental health centers, and in part how could administratively some of these drawbacks be compensated with, or what strategies can we use to compensate for these drawbacks. So it's been a pleasure talking to you all about this. Now, if you are in my summer 2016 class, remember, this isn't the only video that you have to watch this week. There's another lecture on forensic mental health evaluation as another area of specialty that counselors can work in. So please make sure you watch that video as well and then respond with your weekly post. And I will look forward to seeing you all at our next class. Have a good one.